You're listening to Musset, a cardiology board review series. No fluff, just facts.
This episode is about aortic regurgitation. We'll cover the types of aortic regurgitation, the presentation and physical exam, medical management, and intervention, including transcatheter and surgical management. So let's start off with the types of aortic regurgitation. In a nutshell, there are 4 clinical scenarios of aortic regurgitation: acute severe AR, which needs urgent surgery; moderate chronic AR, which needs regular follow up; severe chronic AR with universal indications for surgery. So then, great, you just refer those to surgery. And severe chronic AR that is asymptomatic. That is the most tricky part. For the severe chronic AR that is asymptomatic, you have to look at the ejection fraction and the end-systolic diameter and other echocardiographic parameters to decide whether or not to refer for surgery. In acute aortic regurgitation, unlike chronic AR, the LV is usually not dilated in acute AR. The murmur on physical exam is barely audible, and the regurgitant color jets on echo are not impressive. The vena contracta is more reliable. Chronic MR is a problem of pure volume overload, whereas chronic AR is a problem of volume and pressure overload. The older you are, the worse you tolerate chronic AR because your ventricle is less compliant. The classification of AR is based on the leaflet length and mobility. Type 1 AR has normal cusp motion with functional aortic annulus dilation or cusp perforation. Type 2 AR has cusp prolapse due to excessive or redundant leaflet tissue. Type 3 AR has cusp restriction due to shortened or poorly mobile leaflet tissue, such that it may even remain open during diastole. Type 1 AR has 4 subtypes: 1A, 1B, 1C, and 1D. Type 1A AR is a dilated sinotubular junction or anywhere above the sinotubular junction in the ascending aorta. Surgical treatment is sinotubular junction remodeling. BAR is dilated aortic root, which may involve one or more segments of the sinuses of Valsalva. Surgical treatment is aortic valve-sparing root replacement. CAR is a dilated aortic annulus. Surgical treatment is annuloplasty. DAR is perforation of an aortic cusp. Surgical treatment is patch repair. Now let's move on to auscultation of AR. The timing of the AR murmur is diastolic, starting at S2 and tapering off before reaching S1. The character is high pitch, blowing, decrescendo. The location will be the 4th left intercostal space. To bring this out, ask the patient to lean forward with held expiration, meaning breathe out and hold it there. If it is heard right of the sternum, then that suggests this aortic root pathology as well. Normally, it should not radiate. The intensity of the AR murmur is proportional to the degree of reduction in the diastolic blood pressure in the widened pulse pressure of aortic regurgitation. In terms of maneuvers, the AR murmur is increased with hand grip, which increases the afterload. How do you distinguish between the murmur of acute severe AR and chronic severe AR? The high-pitched murmur of chronic AR begins with the aortic component of S2 and has an early peak and dominant decrescendo pattern throughout diastole. In contrast, in acute severe AR, for example, AR caused by infective endocarditis or aortic dissection, the diastolic murmur is short in duration and tends to be soft because the aortic diastolic pressure rapidly equilibrates with the steep rise in diastolic left ventricular pressure. In acute AR, as I mentioned, a murmur is often not heard because there's no significant gradient between the LV and the aorta. AR-related physical exam findings beyond high-pitched blowing decrescendo murmur are as follows. There are more than a dozen named physical exam findings. Corrigan's pulse, which is also known as water hammer pulse, is rapid, forceful pulse with quick collapse. That's high systolic, low diastolic pressure. Quincke's sign is visible capillary pulsations in the nail beds with gentle pressure. The Musset sign is the head bobbing with each heartbeat. Muller's sign is pulsations of the uvula with each heartbeat. Traube's sign is pistol shot sound heard over the femoral arteries. Durosier's sign is to and fro murmur over femoral artery with light compression. Hill's sign is systolic blood pressure in the legs greater than 20 millimeters of mercury, higher than in the arms. Becker's sign is visible pulsations of the retinal arteries. Landolfi's sign is rhythmic constriction and dilation of pupils with a heartbeat. Maine's sign is diastolic blood pressure dropping more than 15 millimeters of mercury when the arm is raised. Rosenbach's sign is pulsations of the liver. Gerhard's sign is pulsations of the spleen. Sherman's sign is visible pulsations of the dorsalis pedis artery. Austin Flint murmur is mid-diastolic rumbling murmur at the apex. When you do M mode through the mitral valve and see fluttering of the anterior leaflet of the mitral valve, that is due to the turbulent jet of aortic insufficiency impacting the mitral valve anterior leaflet. This is the echocardiographic correlate of the Austin Flint murmur on physical exam. Remember, Austin Flint murmur is the mid-diastolic rumbling murmur at the apex. Pre-closure of the mitral valve is another sign of rapidly rising left ventricular end-diastolic pressure due to AR. The echocardiographic M mode may show that the mitral valve is closed prior to the onset of the QRS. In terms of other imaging, chest x-ray of a patient with aortic regurgitation will show enlargement of the left ventricle, causing the cardiac apex to be displaced downward to the left and posteriorly. In addition, the ascending aorta may be dilated. But that's extremely subtle to figure out on a chest x-ray, so don't even bother trying. Quantifying the severity of aortic regurgitation is a beast. Because it involves a lot of math and physics concepts, I will devote the entire next episode just to quantifying the severity of AR. Let's just move on to management. We'll start with medical management. The highlight of chronic AR management is control of hypertension and afterload reduction via vasodilation. This can be accomplished preferably by ACE inhibitors, ARBs, or ARNIs if there is reduced LV ejection fraction. Mifedipine and hydralazine or nitrates are reasonable as well. If the AR patient is asymptomatic and has a normal ejection fraction with no hypertension, then you can't add ACE inhibitors unless there is some other indication. Unfortunately, randomized trials of ACE inhibitors and calcium channel blockers have not consistently shown benefit in terms of delaying the need for AV replacement or blunting progression of LV dilation. Severe AR is a contraindication to using an intra-aortic balloon pump. If the AR is acute instead of chronic, you need urgent surgery, and prior to that, give nitroprusside to decrease afterload, and consider inotropes and chronotropes to decrease diastolic time, thus shortening the duration of AR in each cardiac cycle. Do not use vasoconstrictors such as phenylephrine or a balloon pump in acute AR, which will worsen regurgitation by increasing afterload. Do not use beta blockers in acute AR, which will block compensation and increase the diastolic gurgitant time, which is what you don't want. Let's see what the 2020 AHA-ACC guidelines on the management of patients with valvular heart disease say about the medical management of AR. In asymptomatic patients with chronic AR, stages B and C valve disease, treatment of hypertension, systolic blood pressure more than 140 is recommended. That's a class 1 recommendation. In patients with severe AR who have symptoms and or LV systolic dysfunction, stages C2 and D, but a prohibitive surgical risk, GDMT for reduced LV ejection fraction with ACE inhibitors, ARBs, and or sacubitril valsartan is recommended, class 1. Now let's talk about intervention. Any AR that is severe and symptomatic automatically gets an AV replacement. That part is straightforward. It is the asymptomatic severe AR patients in whom you need to pay attention to LVEF, LV end-systolic diameter, and LV end-diastolic diameter. LV systolic function is an important determinant of survival and functional status after aortic valve replacement for AR. Outcomes are better when aortic valve replacement is performed before the LV ejection fraction declines below 55%, even in asymptomatic patients, which is why in asymptomatic patients with LVEF declining to 55% or less, it is a class 1 indication to take them to aortic valve replacement despite the lack of symptoms. Widening of the LV end-systolic diameter or LVESD in chronic AR reflects both the severity of LV volume overload and the severity of LV systolic shortening. If the LVEF somehow manages to remain preserved at more than 55%, despite the widening of the LV end-systolic diameter to more than 5 centimeters, that means a significant amount of LV remodeling has happened, and there is going to be impending symptoms and impending LV systolic dysfunction, as well as increased mortality post aortic valve replacement. Indexing for body size to LV end systolic diameter index, LVESDI, more than 55 millimeters per meter square is especially important for women and small sized patients. LV end systolic diameter is uh, 40 millimeters or less in men and 35 millimeters or less in women. Normal end systolic diameter index is 21 millimeters per meter square or less. Widening of the LV end-diastolic diameter, LVEDD, in chronic AR reflects the severity of LV volume overload, foreshadowing subsequent need for aortic valve replacement. If the LV ejection fraction falls at a low normal range, it suggests that the LV is starting to be unable to compensate for the high degree of regurgitation falling back into it. Since these are asymptomatic patients you are sending to AV replacement, you need to make sure that these changes in LV end-diastolic diameter and LV ejection fraction are not measurement variability. Normal LV end-diastolic diameter is 58 millimeters or less in men and 52 millimeters or less in women. In patients undergoing CABG, mitral surgery, valve surgery, or surgery for correction of dilated ascending aorta or aortic root, getting the AV replacement done at the same time will save the patient from the adverse hemodynamic consequences of persistent AV replacement during the peri-operative period, and also from the need for a second sternotomy and cardiac operation in the future. Please remember the cutoffs for LVEDD and LVESD that are used to decide management in asymptomatic severe AR, stage C. Normal LV end systolic diameter is 30 millimeters or less in men, 35 millimeters or less in women. LV end systolic diameter that prompts referral for AV replacement is more than 50 millimeters, whereas the LV end systolic diameter that prompts referral for mitral valve surgery in mitral regurgitation is LV end systolic diameter of 40 millimeters or more. Again, LVESD of more than 50 millimeters prompts referral to aortic valve surgery, whereas LVESD of 40 millimeters or more prompts referral for mitral valve surgery and mitral regurgitation. Normal LV end-diastolic diameter is 58 millimeters or less in men and 52 millimeters or less in women. LV end-diastolic diameter that prompts referral to AV replacement is more than 65 millimeters on at least 3 studies. So also note that LVEDD is the one that requires you to demonstrate that number is more than 65 millimeters on at least 3 echocardiographic studies, whereas LV end systolic diameter does not have that requirement of being demonstrated on at least 3 studies. Once again, LVESD that prompts referral for surgery for AR is more than 50 millimeters, whereas LVEDD has to be more than 65 millimeters on at least 3 studies to prompt referral for AV replacement. What exactly did the 2020 valve disease guidelines say about intervention of AR? In symptomatic patients with severe AR, stage D, aortic valve surgery is indicated regardless of LV function. That's a class 1 recommendation. In asymptomatic patients with chronic severe AR and LV systolic dysfunction, EF of 55% or less, stage 2 C2, aortic valve surgery is indicated if no other cause for systolic dysfunction is identified, class 1. In patients with severe AR, stage C or D, who are undergoing cardiac surgery for other indications, aortic valve surgery is indicated, class 1. In asymptomatic patients with severe AR and normal LV systolic function, EF of more than 55%, aortic valve surgery is reasonable when the LV is severely enlarged, LVESD more than 50 millimeters, or index LVESD more than 25 millimeters per meter square, class 2A. In patients with moderate AR, stage B, who are undergoing cardiac or aortic surgery for other indications, aortic valve surgery is reasonable, class 2A. In asymptomatic patients with severe AR and normal LV systolic function at rest, LVEF more than 55%, and low surgical risk, aortic surgery may be considered when there is progressive decline in LVEF on at least 3 serial studies to the low normal range of 55% to 60%, or a progressive increase in the LV dilation into the severe range of LVEDD of more than 65 millimeters, class 2B. In patients with isolated severe AR who have indications for SAVR and are candidates for surgery, TAVI should not be performed, class 3 harm. So, to recap, if severe AR is asymptomatic, you can still do aortic valve replacement if LVEF is 55% or lower. If LV is severely enlarged, LV end-systolic dimension is more than 50 millimeters, or LV end-systolic dimension index is more than 25 millimeters per meter square, or if there is a need for other cardiac or aortic surgery, or if there's a progressive decline in ejection fraction on at least 3 serial studies to a low normal range EF of 55% or 60%, or a progressive increase in the LV size into the severe range with an end-diastolic dimension of more than 65 millimeters. So that's what I have for you for types of aortic regurgitation, physical exam findings and presentation, medical management, and intervention. Stay tuned for the next episode where we delve into quantifying the severity of aortic regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.